Hello and welcome to part 4 of clinical cases for the cardiovascular system. Today we're going to be taking a look at the final bunch of cases that we were taught about in the cardiovascular block, and these include heart failure, cardiomyopathy, cardiac arrest, and some congenital abnormalities of the cardiovascular system as well. So let's start by taking a look at heart failure, and first of all we take an overview look at heart failure before breaking it down into the two functional types. So heart failure essentially is when the heart is no longer able to pump sufficiently the amount of blood flow the body needs or the oxygen delivery to the organs and tissues that the body requires. As a result, this will manifest in shortness of breath, fatigue and edema, particularly in the legs. But risk factors for developing heart failure, things that would increase your risk of developing heart failure, include smoking, having a sedentary lifestyle and excessive alcohol intake. The more direct causes behind heart failure include a heart attack or an MI, which may cause scarring or fibrosis, a high blood pressure, so chronic hypertension, arrhythmias, infection, but overall the key mechanism usually that results in heart failure is heart damage and scarring, and of course this can arise from a multitude of different cardiovascular conditions. In terms of diagnosis of heart failure, this can be done in several ways. Obviously an in-depth medical history always helps with any diagnosis, but really we want to be reviewing the symptoms and ordering X-rays, ECGs and echocardiograms, because echocardiograms really allow you to visualize the heart and therefore allows you to visualize the ventricles and the atria and see what's really going on inside the heart. X-rays of course really allow you to rule out any other pathophysiology, and ECGs are really important to show any abnormalities. Usually heart failure is accompanied by some kind of abnormality such as an arrhythmia. With regards to treating heart failure as an overview, we can use ACE inhibitors, so these vasodilate, in other words they improve our blood pressure, and they decrease the workload overall on the heart. Angiotensin II receptor blockers, this works in the same way as ACE inhibitors, but they're less likely to give you the chronic cough that ACE inhibitors can give you. Beta blockers are a very commonly used drug, and these slow the heart rate and reduce the blood pressure, so overall this improves the heart function because it's beating less frequently, and obviously the preload is less as we're reducing the BP. Aldosterone antagonists, these are potassium sparing diuretics. These block aldosterone release, so they work really in a very similar way to ACE inhibitors in the long term. Digoxin can also be used, so this improves contractility and slows the heart rate as well. As well as these drugs, of course, we can use hydralazine and nitrates as well, because these also help with vasodilation and make it easier for the heart to receive blood. In terms of treatment of heart failure, essentially it's long-term management more than treatment, and medication really just help in one type of heart failure more than the other, but we'll explore this in a second. One classification system to be aware of is the New York Heart Association classification, and it's quite a simple classification to be aware of and easy to grade. So it's class 1 to 4, with class 1 having no symptoms, class 2 can perform everyday activities with no difficulty, class 3 has some difficulty completing everyday activities, and class 4 is the most severe and is short of breath even at rest. The two types of heart failure are heart failure with a preserved ejection fraction and heart failure with a reduced ejection fraction. So for this you need to understand what ejection fraction is, and essentially it's a measure of how well the heart is pumping the blood out in systole. So an ejection fraction is volume of blood ejected from a ventricle of the heart with each beat, and it's usually calculated by dividing the stroke volume, so remember the volume of blood pumped from the left ventricle per beat, by the end diastolic volume, in other words how much of blood is in the left ventricle before the systole at the end of diastolic filling. As a result, it gives you a percentage, and the target in clinical practice really should be above 50%, that's the borderline, and above 55% really. It depends on the source you use in terms of what they say is the normal. So, heart failure with preserved ejection fraction. First of all, the ejection fraction is normal. This indicates that it's a diastolic problem. It's a problem with the filling of the ventricle, and this is usually seen in the elderly patients. The prevalence of preserved ejection fraction heart failure is actually increasing within the developing world, and this is due to increased prevalence of common risk factors such as hypertension, an increase in elderly population, female sex, metabolic syndromes and renal dysfunction and obesity, all risk factors that are gradually increasing in a developing world and therefore increasing the prevalence of heart failure with preserved ejection fraction. This can be diagnosed in the same way we just discussed as normal heart failure can be diagnosed, and therefore one key characteristic is we always look for the BNP, so this will probably be raised in a heart failure patient. The causes of heart failure with preserved ejection fraction are ventricular dysfunction, so impaired relaxation, impaired filling, and systolic dysfunction. Atrial dysfunction, so a problem with the atria not getting the blood properly to the ventricles. An autonomic dysfunction, so a problem really resulting from the nervous aspect. Vascular dysfunction, so blood problems, so vascular stiffening, for example, or ventricular arterial coupling, and elevated blood pressure, so that chronic hypertension or pulmonary hypertension can also play a role. In terms of treatment, again, we discussed the medication that can be used. It can be used in these patients as well, but they're less commonly used really in these patients. They're more commonly used in the reduced ejection fraction patients. In the case of preserved ejection fraction heart failure, there's not an awful lot we can do, and clinical trials have showed that there's very little evidence which benefits the patient in these cases with medication or surgical treatment. So heart failure with reduced ejection fraction next, and essentially this is what it says: the ejection fraction is reduced, and this is the equivalent of a systolic heart failure, or the majority of cases of reduced ejection fraction heart failure are a systolic aspect or left-sided heart failure. In other words, there's a problem with the pumping. There's a dysfunction of the heart when it contracts, when the ventricles contract and try to eject blood out of the body. In this case, the ventricles do have a reduced capacity, therefore, to eject blood out, and this could be due to an impaired contractility of the ventricles or due to pressure overload. But either way, you're going to see a fall in the stroke volume and therefore probably a fall in the cardiac output as well. As a result, the symptoms that are seen in this case are dyspnea, fatigue, edema, and a reduced exercise tolerance, and some patients will also have an irregular heart rate. Because the causes of reduced ejection fraction heart failure are damage to the myocardium, meaning it cannot pump as effectively. So this could be, for example, long-standing hypertension, which makes it harder for ventricles to pump out, or the ventricles may remodel and become thicker to compensate for this, but in the long term, this actually makes it harder to deliver oxygen to the entire muscular wall of the heart. So really it is a vicious circle as to the heart tries to compensate, but actually this only causes further dysfunction. It can cause death essentially, and the ventricular walls in this case will stretch and become really thin. In the preserved ejection fractions, the ventricular wall will hypertrophy and thicken and therefore become ischemic because blood won't be able to reach a hole of the wall. So there's two mechanisms there in which ways heart failure can cause death. But either way, the heart cells will become damaged. It can cause an arrhythmia, and it's usually a spontaneous arrhythmia that causes death in these patients. Heart block next, or AV block. So this is an abnormal heart rhythm or bradycardia, and in heart block the electrical signals are responsible for contraction become partially or totally occluded between the atria and the ventricles. Usually this is due to the fact that the signal cannot pass due to previous damage or fibrosis to the conduction system. And remember, your normal conduction system is from the SA node to the AV node, to your AV bundle as such, down through your bundle branches or your bundle of His, and out through your Purkinje fibers contracting your ventricles. The causes of heart block include damage or fibrosis, as we've said, so this can happen in several different cardiovascular pathologies, but overall it's causing fibrosis and damage to the conduction system, leading to that impulse not being passed on as it should be. Some causes of heart block are idiopathic, we don't know, but also it could be progressive or due to the patient being elderly, so the aging process, or younger, for example a heredity process. There are many different causes that can cause heart block. But again, be aware of the classification. So first degree, this is where you've got a delayed signal, but it's still reaching the ventricles. And usually in these patients there aren't any symptoms, and they have a prolonged PR interval on an ECG. Then there's second degree heart block, and this can be split into two. So second degree part 1 essentially is where the signal still makes it to the ventricles as it does in first degree, and it's delayed up to a point where the signal does not make it to the ventricles, and we call this a dropped beat. So the PR is progressively getting longer until it's blocked completely at a point, and then it starts again, and then it's dropped again at another point. Part 2 of the second degree is where there's intermittent dropping beats, but this is random, so there's no progressive PR, it's just random points that you get this dropped beat. Third degree, or complete block, this is where it does not reach the ventricles every time, so you get escape QRS waves, but regular P waves. So you'll see a regular P wave on an ECG, but it will not always be followed by a QRS wave. Occasionally it might miss a QRS wave and you just get a random QRS wave somewhere else. You can manage heart block by identifying the underlying cause, whether it be medication or infection, and you can give medication to increase the heart rate, or pacemakers as well. And remember, pacemakers can be transcutaneous or permanent. Next we have bundle branch block, and this is another type of heart block, but here the bundles are being blocked, or the bundles of His. Either the left hand side or the right hand side is being blocked, which causes one ventricle to contract before the other. Bundle branch block is usually caused by fibrosis, so again scarring, and it can be an acute or chronic cause. So acute causes include ischemia from an MI or myocarditis, and chronic causes include hypertension, coronary artery disease, and cardiomyopathies. If you have a right bundle branch block, the signal passes normally down the left-hand side to the Purkinje fibres, but there's a blockage on the right-hand side, which means the signal is delayed getting to the Purkinje fibres, and therefore the left ventricle contracts before the right ventricle. The opposite happens with a left bundle branch block, and there are clear ECG changes to show this. So this is a normal V1 and V6. So remember, V1 and V6 on the ECG should be opposite because we're looking at the heart from different planes. In a left branch block on V1 you'll see a W shape, and on the left branch block in V6 you'll see an M shape, so inversion W and M. In a right bundle branch block you'll see the opposite, so on V1 you'll see an M shaped QRS, and then on V6 you will see a W shape. In terms of symptoms of bundle branch block, you'd see shortness of breath, bradycardia, and lightheadedness and chest pain normally. Next, cardiac arrest. So this essentially is a triad of symptoms, so a loss of consciousness and unresponsive, loss of normal breathing or apnea, and loss of pulse and blood pressure. The causes behind cardiac arrest could be an influx problem of the heart, a congenital heart disease, valvular heart disease. Pretty much anything can lead to cardiac arrest. In terms of symptoms, they can be immediate and drastic, so sudden collapse, no pulse and no breathing. And we approach this with, of course, our ABCD approach: airway, breathing, circulation, and either disability in the normal case, but in this case we're looking at defibrillation as the treatment. So the stopping of fibrillation of the heart by administering that controlled electric shock to allow the restoration of that normal sinus rhythm. Essentially, defibrillation procedures vary depending on the trust, so please check it out depending on what hospital you're in. This is an example of fibrillation, and here the shock has been administered at the red part and normal sinus rhythm re-engages. Cardiomyopathy, essentially this is a diseased heart muscle that cannot function adequately, and it results in the failure of the heart muscle to meet the needs and demand of oxygen-rich blood for the tissues, and the removal of CO2 and other waste products. So there are many causes of cardiomyopathy, but the end result essentially is a weakened heart that cannot do its normal ejection fraction. It cannot pump blood the way it normally should. Symptoms of cardiomyopathy, they may be asymptomatic in the early stages, but eventually they will develop breathlessness, whether that be on exertion or at rest, fatigue, peripheral edema, and also you'll notice a pounding, rapid or fluttering heartbeat, they may describe it as. In terms of complications of cardiomyopathy, heart failure is the main complication, but blood clots, valve problems and cardiac arrest can also ensue. And it's good to be aware that there are different types of cardiomyopathy. So you could have a dilated cardiomyopathy where the ventricle dilates, hypertrophic where the ventricles undergo hypertrophy, or restrictive cardiomyopathy, which is where they become rigid and less elastic. Lastly, for this video we take a look at some of the congenital abnormalities that can occur within the cardiovascular system. Tetralogy of Fallot essentially is where you get 4 common birth defects all together. These are a ventricular septal defect, so you get a hole between the left and right ventricle, which causes a passage of deoxygenated blood into the left ventricle from the right. You have an overriding aorta, so in other words you get an enlarged aortic valve, which appears to rise on both ventricles. Pulmonary stenosis, so of course this is a valvular abnormality. And right ventricular hypertrophy as well, which is trying to compensate for that pulmonary stenosis. Normally this is picked up fairly quickly because you will see cyanosis in patients due to that mixing of oxygenated and deoxygenated blood. The oxygenated blood isn't properly perfusing the tissues, so therefore you'll see cyanosis, and it's usually therefore diagnosed in the first few days of life. So next we have transposition of the great arteries, and this essentially is where you get a swapping of the aorta and the pulmonary artery. So normally you'd expect deoxygenated blood to enter the right atrium, go through to the right ventricle and out via the pulmonary artery to the lungs. However, in this case it doesn't, it leaves via the aorta, so deoxygenated blood is being pumped to the body. And you'd normally expect oxygenated blood to enter the right atrium, right ventricle, and then up through the aorta to the body, but in this case it's leaving via the pulmonary trunk, so you're sending oxygenated blood to the lungs. This causes cyanosis in newborns, and there must be a connection between the right hand side and left hand side of the heart in order to make this compatible with life, otherwise oxygenated blood wouldn't reach the tissues. So finally for this video we have coarctation of the aorta, and this essentially is a congenital abnormality in which the aorta is narrowed, so that's what coarctation means, it's a narrowing. And the area that's usually affected is where the ductus arteriosus inserts, so that fetal remnant. There are 2 types, so there's infant type coarctation and adult type, and infant type is much more common. This is where you get coarctation of the aortic arch before the ductus arteriosus, and this results in the mixing of oxygenated and deoxygenated blood, which is intended for the lungs, travelling through the aorta instead of due to the shunt. And you get the adult type, which is much less common, which is where the coarctation is just distal to the ligamentum arteriosum. The ductus arteriosus is no longer patent and therefore has been replaced by the ligament, and there's no mixing of oxygenated and deoxygenated blood. These are detected fairly early on, and echocardiogram, ECG and chest x-ray allows detection, and a balloon dilatation to widen the aorta is normally for treatment. That's everything for this video. I do hope you found it useful. If you do have any questions, please feel free to contact me. Thank you for listening.